US guided percutaneous release of trigger finger by using a 21 gauge needle, my new tutorial and my last tips. Before starting, the diagnosis of trigger finger must be confirmed by clinical examination and ultrasound. This is a grade 3 case requiring the use of the other hand to release the finger. On these images of the short axis of the finger, you will notice the usual ultrasound signs: thickening of the A1 pullae, Doppler hyperemia, and thickening of the flexor tendons distal to A1. There is a corresponding dynamic sagittal view with the limitation of the superficial flexors gliding under pullae A1. To perform the procedure, you will need a steroid drape, a steroid probe cover, steroid gel, compresses, two kinds of compresses, corticosteroid, 2 needles, orange and green, 5 cc syringe, and anesthetic lidocaine. Now, step 3, positioning the patient and assessing asepsy. The patient lies down on a stretcher with a hand flat on a table. Place the sterile drape in position and disinfect the finger. Step 4, anesthesia. A 25 gauge orange needle is used. The distal part of the A1 pullae is targeted. The gel pad technique allows the needle to be placed in the correct direction before even penetrating the patient's skin. 3 cc of lidocaine are injected under the skin around the A1 pullae and into the flexor sheath. Step 5. Prepare the corticosteroid and bend the 21 gauge needle. Doing this now allows time for anesthesia to take effect. Hold the green needle at its base with both hands. Place the bevel sideways, laterally, and bend the needle to 145 degrees. This provides the tool needed for release. Now, step 6. Release. The needle is positioned as the distal part of pullae A1. Its correct position is checked longitudinally and transversally. Note that the ideal needle angle is between 30 to 45 degrees. With upward movements from the position described, you can feel and even hear the pullae section. Here is a close-up of these upward movements, starting at the distal part of the pullae and moving toward its proximal portion in successive 2 mm sections. Sometimes the angle is not enough to get the pullae section. Here is my trick for increasing the angle. The needle is positioned at an angle to the finger rather than strictly sagittal, which allows the needle to be angled even further as it passes through the interdigital space, as you can see here. When you think it is finished, check the release by moving the needle upwards. Step 7. Corticosteroid injection to limit the inflammatory response. Finally, we clinically verify the result of the release. Here, the result is good right away. The procedure is complete. Out of curiosity, we can check with an ultrasound scan that flexor tendons are sliding properly under pullae A1 and the section of the pullae. And of course, we finish with a compressive dressing. And now, it's your turn to try. Do it yourself.